The diseases of the respiratory system. Bronchial asthma. Obstructive lung diseases. Restrictive pulmonary diseases. Pulmonary infection. Lung tumors. Diseases of the pleura. Bronchial asthma. Objective 1. Introduction to respiratory system. Contrast obstructive versus restrictive lung disease. Understand the use of the FeV1/FVC ratio in classifying lung diseases. FeV1 equals forced expiratory volume at 1 second, FVC equals forced vital capacity. 2. Asthma. A. Define asthma. B. Compare and contrast immune-mediated and non-immune-mediated forms of asthma in terms of initiating factors and pathogenic mechanisms. C. Understand the term bronchial hyperresponsiveness and its relationship to types of asthma. D. Describe the morphologic changes in chronic asthma, and discuss the clinical course. 3. Define bronchiectasis. Describe the gross anatomic lesion, and list the conditions that predispose to its development. 4. Define atelectasis. Introduction, anatomy. Introduction, physiology. Spirometer is an equipment used for measuring the volume of air inspired and expired by the lungs. Pulmonary function tests. Introduction, physiology. Introduction, physiology. Flow volume loop FeV1/FVC ratio is used in classifying lung diseases. FeV1 equals forced expiratory volume at 1 second, FVC equals forced vital capacity. Obstructive and restrictive pulmonary diseases. Diffuse pulmonary diseases are divided into 1. Obstructive disease, characterized by limitation of airflow owing to partial or complete obstruction at any level from trachea to respiratory bronchioles. Pulmonary function test. Limitation of maximal airflow rate during forced expiration, FEVI. 2. Restrictive disease, characterized by reduced expansion of lung parenchyma with decreased total lung capacity while the expiratory airflow rate is near normal. Occur in 1. Chest wall disorder. 2. Acute or chronic, interstitial and infiltrative diseases. For example, ARDS and pneumoconiosis. Obstructive disease. Restrictive disease. Pathology of lung diseases. Very important in clinical medicine. Complication of air pollution. Common symptoms. Dyspnea, difficulty with breathing. Decreased compliance, fibrosis. Increased airway resistance, CH. Bronchitis. Chest wall disease, kyphoscoliosis, obesity. Fluid accumulation, left-sided heart failure. Cough. Postnasal discharge, GERD, BR. Asthma, CH. Bronchitis, pneumonia, bronchiectasis, drug-induced. Hemoptysis. CH. Bronchitis, pneumonia, TB, bronchiectasis, aspergilloma. Atelectasis, collapse. Incomplete expansion of the lungs or collapse of previously inflated lung substance. Significant atelectasis reduce oxygenation and predispose to infection. Types of atelectasis: resorption atelectasis, compression atelectasis, contraction atelectasis. Atelectasis. A telectatic lung is prone to develop superimposed infection. It is reversible disorder except for contraction atelectasis. It should be treated promptly to prevent hypoxemia. Chronic obstructive pulmonary disease. Emphysema. Bronchiectasis. Chronic obstructive pulmonary disease. Chronic bronchitis. Asthma. Bronchial asthma. chronic relapsing inflammatory disorder characterized by hyperactive airways leading to episodic, reversible bronchoconstriction owing to increased responsiveness of the tracheobronchial tree to various stimuli. Triad of intermittent and reversible airway obstruction, chronic bronchial inflammation with eosinophils, bronchial smooth muscle cell hypertrophy and hyperreactivity. Bronchial asthma triggered by environmental antigens, such as dusts, pollen, animal dander, foods. Potentially any antigen is implicated. Drugs, aspirin, sulfur dioxide, ozone, and nitrogen dioxide. Bronchial asthma has been divided into two basic types. 1. Extrinsic asthma. 2. Intrinsic asthma. Extrinsic asthma 70% classification of asthma. Intrinsic asthma 30%. Initiated by diverse, non-immune mechanisms, including ingestion of aspirin, pulmonary infections, cold, inhaled irritant, stress, exercise. No personal or family history of allergic reaction. Developed later in life. Initiated by type 1 hypersensitivity reaction induced by exposure to extrinsic antigen. Subtypes include A. Atopic, allergic, asthma. B. Occupational asthma. C. Allergic bronchopulmonary aspergillosis. Develop early in life. Extrinsic asthma. Atopic, allergic, asthma is the most common form, begins in childhood. Other allergic manifestation, allergic rhinitis, urticaria, eczema. Skin test with antigen result in an immediate wheal and flare reaction. Other family member is also affected. Serum IgA and eosinophil are increased. Immune-related, Th2 subset of CD4 plus D cells. Pathogenesis of bronchial asthma. Exaggerated bronchoconstriction. 2 components. 1. Chronic airway inflammation. 2. Bronchial hyperresponsiveness. The mechanisms have been best studied in atopic asthma. Pathogenesis of atopic asthma. A classic example of type 1 IgA-mediated hypersensitivity reaction. In the airway, initial sensitization to antigen, allergen, with stimulation of Th2 type T cells and production of cytokines, IL-4, IL-5, and IL-13. Cytokines promote 1. IgA production by B cell. 2. Growth of mast cells. 3. Growth and activation of eosinophils. Pathogenesis of atopic asthma. IgA-mediated reaction to inhaled allergens elicits 1. Acute response, within minutes. 2. A late phase reaction, after 4 to 8 hours. Pathogenesis of atopic asthma. Acute phase response. Begin 30 to 60 minutes after inhalation of antigen. Mast cells on the mucosal surface are activated. Mediator produced are leukotriene C4, D4 and E4, induce bronchospasm, vascular permeability and mucus production. Prostaglandins D2, E2, F2, induce bronchospasm and vasodilatation. Histamine, induce bronchospasm and increased vascular permeability. Platelet activating factor, cause aggregation of platelets and release of histamine. Mast cell tryptase, inactivate normal bronchodilator. Mediators induce bronchospasm, vascular permeability and mucus production. Pathogenesis of atopic asthma. Late phase reaction. Recruitment of leukocytes mediated by product of mast cells including 1. Eosinophil and neutrophil chemotactic factors. 2. IL-4 and IL-5 and induce IF2 subset of T4 plus D cells. 3. Platelet activating factor. 4. Tumor necrosis factor. Other cell types are involved: activated epithelial cells, macrophages and smooth muscle. Pathogenesis of atopic asthma. Late phase reaction. The arrival of leukocytes at the site of mast cell degranulation lead to 1. Release of more mediators to activate more mast cells. 2. Cause epithelial cell damage. Eosinophils produce major basic protein, eosinophilic cationic protein and eosinophil peroxidase, toxic to epithelial cells. These amplify and sustains injury without additional antigen. Non-atopic asthma. Triggered by respiratory tract infection including viruses and inhaled air pollutants, for example sulfur dioxide, ozone. Positive family history is uncommon. Serum IgA, normal. No other associated allergies. Skin test, negative. Hyperirritability of bronchial tree. Subtypes. 1. Drug-induced asthma. 2. Occupational asthma. Morphology of asthma. Grossly, lung overdistended, overinflation, occlusion of bronchi and bronchioles by thick mucus. Histologic finding. Thick BM. Edema and inflammatory infiltrate in bronchial wall. Mucus contain Kurskman spirals, eosinophil and Charcot-Leyden crystals. Submucosal glands increased. Hypertrophy of the bronchial wall muscle. Kurskman spirals. Coiled, basophilic plugs of mucus formed in the lower airways and found in sputum and tracheal washings. Charcot-Leyden crystals. Eosinophilic needle-shaped crystalline structures. Clinical course. Classic asthmatic attack, dyspnea, cough, difficult expiration, progressive hyperinflation of lung and mucus plug in bronchi. This may resolve spontaneously or with Rx. Status asthmaticus, severe cyanosis and persistent dyspnea, may be fatal. Superimposed bacterial infection may progress to emphysema or chronic bronchitis. Asthmatic bronchitis, chronic bronchitis with superimposed asthma. Bronchiectasis. Chronic obstructive pulmonary disease. Emphysema. Bronchiectasis. Chronic obstructive pulmonary disease. Chronic bronchitis. Asthma. Bronchiectasis. Chronic necrotizing infection of the bronchi and bronchioles leading to or associated with abnormal dilatation of these airways. Bronchial dilatation should be permanent. Conditions associated with bronchiectasis. Bronchial obstruction. Congenital or hereditary conditions. Necrotizing pneumonia. Localized. Tumor, foreign bodies or mucus impaction. Generalized. Bronchial asthma. Chronic bronchitis. Congenital bronchiectasis. Cystic fibrosis. Intralobar sequestration of the lung. Immunodeficiency status. Motile cilia and Cartignan syndrome. Caused by TB, staphylococci or mixed infection. Cartagena syndrome inherited as autosomal recessive trait. Patient develop bronchiectasis, sinusitis and situs invertus. Defect in ciliary motility due to absent or irregular dining arms. Lack of ciliary activity interferes with bronchial clearance. Males have infertility. Bronchiectasis etiology and pathogenesis: obstruction and infection. Bronchial obstruction, atelectasis of airway distal to obstruction, bronchial wall inflammation. These changes become irreversible. 1. If obstruction persists. 2. If there is added infection. Morphology of bronchiectasis usually affects lower lobes bilaterally, vertical airways. Dilated airways up to 4 times of normal, reaching the pleura. Acute and chronic inflammation, extensive ulceration of lining epithelium with fibrosis. Bronchiectasis. Bronchiectasis clinical course. Severe persistent cough with sputum, mucopurulent, fetid sputum, sometime with blood. Clubbing of fingers. If severe, obstructive pulmonary function develop. Rare complications, metastatic brain abscess and amyloidosis. Summary. Asthma. Bronchiectasis. Asthma, dyspnea and wheezing. Types. 1. Extrinsic asthma, type 1 hypersensitivity reaction, EGA, childhood, family HX of allergy. 2. Intrinsic asthma, associated bronchial asthma, aspirin, exercise, cold-induced, no HX of allergy. Morphology. Hypertrophy of bronchial smooth muscle and hyperplasia of goblet cells eosinophils. Mucus plug Ecosquin spirals and Charcot-Leyden crystals. Complication. Superimposed infection. Chronic bronchitis. Pulmonary emphysema. Status asthmaticus. Bronchiectasis, infection obstruction. Chronic necrotizing infection of the bronchi and bronchioles leading to permanent dilatation of these airways. Bronchiectasis. Causes. Infection. Obstruction. Congenital, cystic fibrosis, cartigenous syndrome. Clinical features. Severe persistent cough with sputum, mucopurulent sputum, sometime with blood. Clubbing of fingers. Complications. If severe, obstructive pulmonary function develop. Lung abscess. Rare complications, metastatic brain abscess and amyloidosis. Questions. What triggers an attack of asthma? Questions. What triggers an attack of asthma? Extrinsic, or allergic, asthma is triggered by environmental allergens, including dusts, pollens, dander, foods, etc. B. The most common provocative agents of intrinsic, non-immune, or idiosyncratic asthma are infections of the respiratory tract, especially viral. Other types of intrinsic asthma include drug-induced asthma, many drugs, especially aspirin, occupational asthma, provoked by fumes, organics, chemicals, and exercise, cold, and emotional stress-induced asthma. What is the mechanism of the early symptoms, and what are the causes of effects that appear several hours after exposure to an allergen? Acute early phase reaction. What is the mechanism of the early symptoms, and what are the causes of effects that appear several hours after exposure to an allergen? Acute early phase reaction. Exposure of pre-sensitized IgA-coated mast cells to the same or cross-reacting antigens results in an acute early phase reaction from the release of histamine, which causes bronchospasm. Leukotrienes, which attract leukocytes and eosinophils and release mucus. Platelet activating factor, which causes more release of histamine and serotonin from platelets. Late phase effects. Cytokines released by leukocytes, eosinophils, and basophils recruited during the early phase contribute to the late phase effects. Histamine from basophils causes bronchoconstriction and edema. Neutrophils cause inflammatory damage. And the major basic protein of eosinophils causes epithelial damage and shedding and contributes to bronchoconstriction. Are all forms of asthma associated with type I hypersensitivity reactions? No. Intrinsic asthma is not triggered by type I hypersensitivity. The precise causes of hyperreactive airways in intrinsic asthma are not known. What is responsible for the accumulation of eosinophils? Eosinophils are attracted by chemotactic factors released by mast cells and also by the chemokinae axon. The latter is produced by bronchial epithelial cells. Eosinophil accumulation is also favored by IL-5, a T-cell-derived cytokine. What role do eosinophils play in causing tissue damage? What role do eosinophils play in causing tissue damage? Major basic protein of eosinophils causes epithelial damage and shedding. Are mucus plugs diagnostic of bronchial asthma? What are the causes of bronchiectasis? The most common conditions are bronchial obstruction, tumors, foreign bodies, diffuse obstructive airway diseases, atopic asthma, chronic bronchitis. B. Congenital or hereditary conditions, congenital bronchiectasis, cystic fibrosis. C. Necrotizing or suppurative pneumonias. Those conditions predispose to chronic necrotizing infections and consequent destruction of muscle and elastic support tissue of bronchi and bronchioles. Why does it seem to affect the lower lobes preferentially? Inhaled materials and secretions tend to gravitate to the lower lobes. What type of inflammatory cells might you expect? Compare with asthma. Acute inflammatory cells, especially PMNs, are present, although evidence of chronic inflammation is also likely to be present. By comparison, in asthma, the inflammatory cells are composed of CD4+ lymphocytes, eosinophils, mast cells, and a few neutrophils. What is the definition of asthmatic bronchitis? Some patients with a clinical definition of chronic bronchitis have hyperresponsive airways with intermittent bronchospasm.